So, good morning to the few assembled here. My name's Ron. I'm an intensive care consultant from Birmingham in the West Midlands of the United Kingdom. I'm here representing today the European Sepsis Alliance. I'm also one of the vice presidents of the Global Sepsis Alliance, and I'm founder and chief executive of the UK-based charity, the UK Sepsis Trust. Now, we are going to start, I am reliably assured, with some questions for the few assembled here, but also for those joining us online. And really, this is around framing this issue, because sepsis is a hidden health emergency. It is intrinsically interlinked with AMR, but we would like to know what people listening to this already know about sepsis and how aware they are of the burden of this issue. So you can join us at slido.com using the hashtag Moon, which is the specific hashtag for this room and for this session around sepsis as a hidden healthcare emergency. And we really would like people to interact with us, both online, we're monitoring, and Beatrice over there is going to be monitoring the social media accounts to ensure that we engage in a robust and energetic discussion around this issue. So before I proceed, shall we start with the polling questions? And the first question really is, who has heard of sepsis? But it's not really that, because if you're in this session, of course you've heard of sepsis. But who knows what sepsis is? Who could describe it to a fellow human being in a rational and reasonable way? That is a different question. Okay, it's a reasonable question, but it's not about sepsis. So would anyone in the room like to describe to me how they would describe sepsis to another human? 2/3 of people have heard. That's pretty standard across European countries. Awareness varies between countries. It's slightly higher than that in the UK because we've been working on this for a long time. It's slightly lower than this in Germany. In other countries, for example, in Latin America, in Brazil, only 15% of people have heard of sepsis. But I think what we really need to reflect on is, are we confident that we could describe it to somebody? Because this is not just about a healthcare systems issue. This is not just policy. This is also around safeguarding each other. So, on to the second question. This is really around the scale of the burden of sepsis. So we'd like to ask with the second question, how many cases of sepsis do we see internationally every year? Is it A, 50 million? Is it B, 2 million? Or is it C, 10 million? So again, those joining online and via social media, please, if you can, join at slido.com. The hashtag is Moon, and help us to interact and to answer these questions. So, in January of 2020, there was a report from the Institute for Health Metrics Evaluation, whom you might not have heard of. You will, of course, have heard of the World Health Organization, and you may well have heard of the Global Burden of Disease Report. And the IHME are the group that compiled the Global Burden of Disease Report on behalf of the WHO. And they provided us with an estimate, and I would stress that these are estimates. They estimated that around the world every year, sepsis affects 49 million people, accounting for 11 million lives lost, with more than half of those lives lost being children under 5 in resource-poor environments. So our learning from our high-income countries and our relatively resilient healthcare systems in Europe will not only safeguard our public in our countries. But also the learning from that will help to improve the lives and improve outcomes for children in resource-poor environments. But these are just data, and statistics are nothing without context. So I'd like to move on to the third question, if I may, which is, among these conditions listed, which one causes the most deaths? And what we hope we're going to find with this is a rank order of threats to life. And we start with with cardiovascular disease, and then sepsis, and then cancer and antimicrobial resistance. Which one of these do those assembled here and those viewing online think claims the most lives around the world? So again, I can see those in the room participating. I can encourage those online to participate, and Beatrice will interrupt me if we have any burning questions arising on the online community. So we have a rank order, and interestingly, it is the correct rank order. Cardiovascular disease is estimated to claim around 18 million lives globally every year, with the majority being from acute coronary syndrome or heart attack and stroke, but also a significant burden from heart failure. Sepsis, as I've described, is estimated to claim 11 million lives around the world every year, placing it just under cardiovascular disease. And sepsis is estimated by the WHO to account for 1 in 5 lives lost worldwide. Underneath sepsis is cancer, with estimates for cancer deaths varying from 8 million per annum to 10 million per annum around the world. And of course, this is not diminishing the importance of efforts to improve outcomes from cancer. It's right and proper we continue to strive to do that. But sepsis claims more lives every year than cancer. And we have to talk about antimicrobial resistance. Antimicrobial resistance was estimated in 2019 to claim just over 1 million lives around the world every year. Now, a number of years ago, Lord O'Neill from the UK issued a report on the threat of antimicrobial resistance and estimated that if we didn't act then, if we don't act now, then by 2050, we will see an additional 10 million lives lost every year around the world as a consequence of antimicrobial resistance. I think that is optimistic. It might not be by 2050, it might not be in my lifetime, but it will certainly be in our children's lifetimes, that if we don't act now on antimicrobial stewardship, on improving the pipeline of new anti-infective agents, as well as improving the use of them, not only in human medicine, but also in agriculture and particularly intensive farming, we will have a problem on our hands. I would put it to you that if we accept the estimate that there are 49 million people developing sepsis every year, if we don't have effective antimicrobials, and it might not be by 2050, but it will certainly be in the order of 2080 and towards the end of this century, we will not be able to treat those 49 million people. And thus the number of lives lost from sepsis will not be 11 million, it will be 49 million. And just to make you think, an additional 38 million deaths around the world every year will change the balance of the human population from a position of growth to a position of decline. And so when people describe antimicrobial resistance as an existential threat, they are not exaggerating. And we have to give it a face, and we have to make it human. But we're here to talk about sepsis, this hidden killer that we've accepted accounts for 11 million lives lost every year. This is an enormous burden on our healthcare systems. Every case of sepsis in Europe is estimated to cost 25,000 euros in direct costs to the healthcare system. Those are just direct costs, the cost of treating patients, the cost of bed days, 25,000 euros for every patient. And we will see approximately 2 to 3 million episodes of sepsis every year across this continent. So you can do the maths for yourself. This is a huge burden on our healthcare system. But the healthcare system is the tip of the iceberg. Sepsis claims lives, but sepsis, as you'll hear in a moment, presents a burden of survival to those who are fortunate enough to survive. And the fiscal costs to our economy in terms of lost productivity from premature death and from inability to return to work are enormous. There was a study in Scandinavia that showed that among working age adults, 43% were unable to return to work at 1 year after their episode of sepsis. And just think what that would mean for you and for your family. You can't return to work. So it was estimated in the UK that the direct costs to the economy, not the healthcare system, were as high as 15.6 billion euros every year. Around Europe, 200 billion euros wasted because we don't recognize sepsis properly, we don't treat it quickly enough, and there are gaps in our system. And just as importantly, we don't resource rehabilitation for people who survive this condition. And we have to change this. But when we're talking about One Health, when we're talking about end-to-end care, we have to consider sepsis in the space of infections management. We would describe that there are 4 pillars of infection management. One is, of course, infection prevention. 2 is antimicrobial stewardship. The 3rd is the rapid treatment of time-critical infections, including sepsis. And the final one is, of course, outbreak surveillance and pandemic preparedness. And only once at a policy level we are considering infection management holistically will we do justice to the 11 million people currently losing their lives. And I'm an intensive care doctor. I don't want to diminish how important and how horrific COVID-19 has been. But again, let's reflect. Every year, sepsis claims 11 million lives. Thus far around the world, COVID has claimed 6.5 million lives. Let's get some context here. Now, I've mentioned the burden of survival, and you've heard enough from me for now. I'm going to deviate from the script because most of our panelists are now joining us online, so we're going to start with a friend and colleague who is here in person. I've talked about the burden of survival from sepsis. I don't have lived experience of sepsis, but Idelette, who's going to speak to us now, does. A former nurse, Idelette suffered septic shock now some years ago and a spell in intensive care. And she's used that experience for good by invigorating a campaign in the Netherlands and a policy statement in the Netherlands to help people who suffer sepsis now and into the future. So, Idelette, please.
Thank you for this opportunity, sharing my story with you. First of all, I'd like to start by saying sepsis is really like a sniper. It comes out of the blue, it often lies hidden, and it's really a public health enemy as well. I got hit by a sepsis in 2007. I was admitted to the hospital with a fever and shortness of breath, and I was a nurse at the time, but I didn't recognize sepsis because I was diagnosed with a double pneumonia and put on antibiotics. And later on, it turned out I had a hantavirus infection, but I didn't know at the time, the doctors didn't know at the time. So I thought, well, the antibiotics, they will get me well soon. But it went differently. I had to go to the toilet in the middle of the night, and I got very dizzy. And I thought, I have to get back to bed very soon. And as I went to bed, I pushed the button to get help. And the nurse measured the blood pressure, which was very low, 70/40. And I remember my hands and feet were so cold and my heartbeat was going like crazy. And all of a sudden, as I coughed, I had mucus and fluid in my mouth. And as a nurse, I thought that was really a bad sign, fluid getting into my lungs. So I thought, I'm going into shock. And it scared the hell out of me. I thought in a few moments, well, life can just slip through your fingers like that. And I was lucky because they transferred me to the ICU right away. That really saved my life, that I was in hospital already. And within 2 hours, I was put on the ventilator, and I had to say goodbye to my family. I was very alert. I remember that. And yeah, we had to say goodbye because we thought it could go either way. And fortunately, after a night that was very critical, I turned the corner the next day. I thank God for that. And I'm very grateful that I survived, that I didn't have to lose my limbs. So I got lucky. But after that, the recovery started. And the struggle for life turned into the struggle with life. Because no one had told me about the sequelae and that you can feel depressed at some times, or about PTSD, or about nerve pains, or your vulnerability. I got readmitted to hospital 3 times in a few years' time. And the tiredness and the lack of energy. I couldn't go back to my previous work. But this triggered me. I wanted to gather every information I could find about sepsis. And I brought it together in a book, which was translated in English too. You can find it on my website, Sepsis and Afterwards. And I started an educational website, Sepsis and Afterwards, to inform the public and professionals about the dangers of sepsis, which can come out of the blue, like a sniper, and to enhance awareness also regarding the aftermath of sepsis. A lot of doctors and the public don't know about the consequences of sepsis. And there's so many people in the general wards as well treated for sepsis. So not in the ICU, not just in the ICU. And they suffer from sequelae too. And struggling to get back to work and finding out that it's too hard, and they just don't manage to get back to work. And we have to get the word out that sepsis is really a health emergency, a public enemy as well. And it's actually the most common critical illness outside the ICU. And, well, we offered a petition in the Netherlands in 2018. It was called SOS for Sepsis, to draw attention to all of this. And we had negotiations with the Ministry of Health, and this resulted in their financial support for building up a sepsis network in the Netherlands, which was really a big step forward. And we had a Sepsis Congress in May of this year, and we hope that we can make a large step again in the sepsis awareness. Because we have to do more, really. We have to. There are a lot of people out there struggling, and they have little energy, and they have to find out everything by themselves, and have to scrape their own aftercare together. That's really astonishing. We have to do better, and a lot more funding for sepsis research and early detection of sepsis. That's also very important. Thank you.
Thank you so much. Thank you so much, Idelette. So I have a question, and if anyone in the audience would like to think of a question for Idelette, then please let us know. But if you had the health minister here now, sitting here, and you had one ask, and the health minister guaranteed to undertake that ask to support people who've been through this problem, what would you want the government to do?
Coordinate and take a central role in a large sepsis campaign. Like in the UK, the Sepsis Trust organized the sepsis awareness campaign. And we have to get it into let's say, the capillaries of society and healthcare. So that everyone who's been through surgery and gets a fever and chills thinks, wow, could it be sepsis? It's on your buses in London everywhere.
Yeah.
I understood. Could it be sepsis? This question. Yeah.
Thank you. Yeah. So this is around public awareness. It's around getting people to healthcare at the right time so that we can act rapidly and hopefully improve outcomes.
Yeah.
So
and organize access to rehabilitation.
Yeah.
Yeah.
There are a couple of questions that I'm seeing on my magic Slido, which I'll deal with, that aren't directly related to your experience, Idelette. So are there any questions in the room for Idelette directly? Please.
Thank you. Magda Rosenmüller, Jesse Business School. Thanks for sharing. This was really, it's good to hear that. We have been working on a potential sepsis education project. So my question would be, if we talk about education, would it be rather patient-citizen education, that the bus, that's fine, but what about the professionals? Like, where would it be rather the GPs, that they're more layered, the emergency rooms in the hospital? So what from your own experience would you say, at which point in your story would you have said, I would have needed someone that would have known exactly that this is, has all the different criteria for being a sepsis, and that would tell us where we should start educating and raising awareness among the health care professionals and executives?
Yeah, thank you. Well, I think it's very important that GPs and nurses, that they're all being educated. I know in the ICU, sepsis is very common, and they have protocols, and that situation is far more better, but GPs and nurses, they should really be taught more about sepsis. You know, I was taught about sepsis during my education to become a nurse, but the only thing I remembered from it was that it could evolve from a peritonitis or a bad wound infection. So we have to invest a lot more in good education and, very important, repeat the education over and over again.
Yeah, I mean, I'd fully agree with that. I think a problem with sepsis education for health professionals internationally is it tends to be led by intensive care doctors. And so we have European modules from the European Society of Intensive Care Medicine. A GP is never going to look at that. A surgeon's never going to look at that. We need to make this holistic across healthcare. Fully agree. I do need to pick up a couple of questions that have arisen, and we'll bring you back in, but we need to move on to the next speaker. So, great question. How is AMR, antimicrobial resistance, defined worldwide? Does it include assessment of the lack of availability of antimicrobials in resource-poor environments? And this is a fantastic question. I've worked in Malawi, and the antibiotic you get in Malawi, if you're lucky, is the one they happen to have in that cupboard on that particular day. So we don't have a selection of antimicrobials in resource-poor countries. The answer to the question is AMR is only counted when we have evidence of resistance. So it requires a resilient healthcare system, it requires strategies to identify pathogens and strategies to identify resistance in pathogens. What these data do not include are the people who don't get better on their antibiotic if they don't have a pathogen identified. And so I think the 1.2 million is probably the tip of the iceberg. But let's remember, I mean, I'm an intensive care doctor. To my knowledge, I've never seen anyone die of antimicrobial resistance. I've seen people die of untreatable infection and untreatable sepsis because of antimicrobial resistance, but the mode of death is the infection, not AMR. And we have to bring these two together. The second question I need to answer is, are AMR and sepsis interrelated? Well, we've sort of discussed that, and I'm conscious this was an earlier question. I want to highlight, we're not just talking about the UK and the Netherlands and Sweden and Germany today. There are fantastic improvement programs going on in many countries throughout Europe and around the world, and we shouldn't just focus on one country. Sepsis has been accused, in terms of national sepsis improvement programs, of fueling antimicrobial resistance because it encourages health professionals to give antibiotics rapidly. But I want to give 3 examples where we evidence that that is not the case. In the UK, where I am, we had a national improvement program, and 80% of people at the end of this improvement program were given antibiotics within 1 hour, and mortality rates went down from 30% to 20% in just a few years. We had no increase in hospital consumption of antimicrobials during that 3-year period. In Ireland, similarly, there was a national sepsis improvement program and no increase in antibiotics, despite an improvement in the reliability of recognition of sepsis and a reduction in mortality rates. New York State, a population of 20 million people, not a small study, but they instituted law around health professionals having to recognize sepsis rapidly, Rory's regulations. And similar to the UK, they had process improvements and their mortality rates dropped from 30% to 20%. They had no demonstrable increase in antimicrobial resistance during that time period. So we can incentivize better sepsis care without fueling increased antimicrobials. The interlink between sepsis and AMR is not that sepsis fuels AMR, but that without attention to AMR, we will find ourselves unable to treat sepsis. And the final one, very briefly, before I move on to Christian, is why is awareness of sepsis so low compared with other prevalent conditions like cancer and cardiovascular disease? Well, it is time and funding. If you look at research studies as one example, it's disproportionate. There is 100-fold higher income and research fund allocation to cancer than there is to sepsis, despite the fact they have a very similar prevalence. The cancer campaigns have been going for longer. The cardiovascular disease campaigns have been going on since the 1960s, and sepsis really only started this millennium. So we've got a long way to go, but there's another reason. People form a relationship with cancer, and they form a relationship with their cancer clinicians. Sepsis comes like that and affects you. And you have a very brief relationship with the condition, and you then form a relationship with the after effects, and it's a very different dynamic. So we should move on. I'd like to introduce, I hope, Dr. Christian Scheer, who is the head of critical care with a background in anesthesiology at Greifswald in Germany. And he's going to talk to us. And we talked about not making this about one country. An incredible survey funded by our sponsors today, Becton Dickinson, for which we're grateful, across 1,200 hospitals. And we're sharing the results, I think, for the first time. And I'm very interested to hear the results. Thank you, Christian.
Good morning from Germany. Thank you very much for the kind introduction and also for taking part in this great meeting. I see my slides. Ladies and gentlemen, today my talk is about the European Sepsis Care Survey, and I want to start with a little bit of background, very brief, and why there was a need for this project. I think many clinicians know these papers. These are the guidelines for sepsis, and since many years we have international published guidelines for the management of sepsis. Since 2004, they are updated every 4 years. And the content of the guidelines are evidence-based recommendations, very clear, and the key elements of the guidelines are early recognition and management of sepsis. And these two things are little changed over time. So we know this since almost 20 years. Since we have these recommendations for a very long time, one would expect that they would be used in most hospitals and are standard of care, because they are crucial for the outcome of patients with sepsis. This is a WHA resolution from 2017 on improving the prevention, diagnosis, and management of sepsis. Implemented standards, guidelines, infrastructure, laboratory capacities, strategies, and tools for identifying sepsis are very clearly mentioned in this resolution. And this resolution once again underlines the importance of actions to respond to sepsis. But now the big question is, do we have sufficient and implemented standards, guidelines, and infrastructure within our hospitals? What do you think? You would think so? My answer is we did not know until now. Because up to now we had no data on this topic, no structures analysis, neither for individual countries nor for the European Union. To get data on this topic, we designed the European Sepsis Care Survey. This is a multidisciplinary cross-sectional analysis of structure and capabilities of sepsis care in hospitals in the European Union, but also worldwide. Our survey had 5 parts: a first general part, then 3 parts about sepsis care in the emergency department, at the wards, at the ICUs, and the last part about quality programs. In total, the survey had 94 questions, very comprehensive. It takes more than 1 hour to participate in the survey. And the content are questions about capabilities, resources, recognition, screening for early detection, guidelines, protocols, diagnostic capabilities, and the implementation of education and training. So very comprehensive. The study design, in the first step, we designed and tested all the questions together with our steering committee. The committee was composed of experts from different European societies. In the second step, the whole survey was reviewed by scientific boards of 3 intensive care and anesthesiology societies. And also our national coordinators tested the questionnaire. The survey was available in English and in some other languages. And the participants had first to do a web-based registration, and then the participation was also web-based. Here you can see a picture from the recruitment in the past year. Hospitals worldwide participated in this project, and you can see that there are participants in many regions worldwide, but most of the hospitals and participants are from European countries. As you can see, we were able to achieve a very well distributed recruitment in many countries and regions, especially in Northern, Eastern, Southern, and Western Europe. These regions are equally and well represented. This figure shows the participated countries, the number of participated countries, hospitals, and the number of beds of the participating hospitals below in the x-axis, very small. The bars are showing the proportion of represented beds for each country. This was calculated on Eurostat data. And this proportion is an indicator of representativity for each country. So you see a bar for each country. And for example, for Croatia, we were able to recruit 23 hospitals, and this represents 90% of the beds in Croatia. The EU countries are displayed in dark blue and the other countries in light blue. In total, we had participants from 60 countries, 25 in the European Union. In total, we included more than 1,000 hospitals in our analysis. Regarding the EU, we were able to achieve a sample representing almost 25 of all beds in the European Union. The responding participants were, for the most part, specialists, head of departments and consultants, so almost or more than 75%. And they were from the emergency medicine, intensive care medicine, infectious disease departments. And most of the hospitals were general, community, university, or teaching hospitals. So I think this is also very representative for the countries. The size of the participating hospitals was in more than the half, between 0 and 500. So the sample is here for smaller and middle-sized hospitals. So what is critical in the treatment of sepsis? This is a question, and now we come to the results, and I will focus on 4 topics. The first topic is sepsis recognition and standard operating procedures for the management of sepsis. The second topic, the availability and presence of laboratories for pathogen identification. Antimicrobial guidelines and antibiotic stewardship are also important, and quality improvement and initiatives about this is a last topic. The results I show you will be presented by hospital size, divided by hospital size. So we have 5 classes here. Hospitals up to 250 beds, from 250 to 500 beds. So these are the smaller and middle-sized hospitals. And the last category are hospitals with more than 1,000 beds. For example, university hospitals, very large hospitals. And we also did the analysis on the country level. Today, I will not show you the country names. They are all blended. I apologize for that, but I think it's not important to know the countries today, but to see the difference between the countries. Yeah, my first topic, sepsis recognition and screening, is very important. You have to identify patients first and very timely, and this is very important for the outcome. Most of the screening tools are very short, are very easy, no rocket science, but you need to have it in mind, and you do have to do the screening and the early recognition. We asked the participants this question: do you have a protocol or standardized screening tool specifically for the recognition of sepsis? And these are the results. You see here the 5 hospital sizes. And for each hospital, you see the answers for the emergency department, for the wards, and for the intensive care units. The emergency departments are gray lined, and the intensive care units are in dark gray displayed. And in total, you see protocols and screening tools are not sufficient. ICUs are a little bit better. Wards are the worst. But also in the emergency department, in 40–50%, we must assume sepsis recognition is by chance. So there is a lot of room for improvement. We see no differences between the hospital sizes. So you see the bigger hospitals are not better than the smaller. And these are the results for the screening. So the next topic is sepsis management, sepsis bundles, protocols, pathways, anything of these. And again, it's very easy. If you focus on 5 aspects, you have at least a sepsis bundle. If you include sepsis, blood cultures, anti-infectives, lactate fluid, resuscitation, vasopressors. Of course, you should do more than this, but if you have these 5 aspects in your hospitals, you have at least a bundle implemented. And this is, again, not very complicated. And we asked the participants, do you have a protocol, a care pathway, or anything else, a bundle for the management of sepsis? And again, the results are very similar to the screening results. In 20 to 60% hospitals had not even the simple sepsis bundle, the 5 simple things in place. Again, the ICUs are a little bit better than the emergency departments and the wards. The wards are worst. And again, we see no difference between the hospital size. So for this topic, there's also a lot of space for improvement. And these are the results for hospitals in the European Union. So they are not the results worldwide. Today, I show you only the results for the European Union. So these are the bad results for us, for our countries. So the next question is, do we have differences between the countries? Because all the results were only on the hospital level. And you can see that we have a lot of differences for sepsis screening and for standard operating procedures between the countries in the European Union. There are some countries which are a little bit better. Some are very well in the ICU, but they had, in some examples here, they had no screening at the emergency department, and there are a lot of differences between the countries, and the problems in the countries are different. So the improvement which we can make is in different parts. For the next results, what is critical in the treatment of sepsis? Sepsis is life-threatening, and rapid pathogen diagnostic is very important. It influences the decision on anti-infective decision making. And we asked the participants about their laboratory structures. Most of the hospitals have the laboratory structures. You see here the gray-lined bars, but they are not 24/7 open. This is a problem. They have only limited opening hours. Larger hospitals are a little bit better, but a little bit better means below 20% open for 24/7 hour. And you see here, this is the problem. 80–90% are not 24/7 open, and this causes delay. We asked the participants, how long does it take to the first result, to the first blood culture result? And that were the answers, and you see here in dark gray, the hospitals which have the service 24/7, they have the results earlier. And this in a very significant proportion. Shorter in the labs with 24/7 service and delayed result in the other hospitals. So there is a lot of desire for improvement, and I want to remind you again, the participants were in most cases head of departments, head of the emergency department, of the intensive care units, and of the wards, medicine or surgery. And they say microbiological diagnostic of sepsis should be more rapid. That was the answer in more than 60% of these more than 1,000 hospitals in the European Union and also worldwide. And more than 40% said also 24/7 service is absolutely needed. So what is critical in the treatment of sepsis? Antimicrobial treatment is a key element of sepsis management, but anti-infective decision-making is not simple. It's not so simple as the screening or the bundles. It's not trivial. This knowledge cannot be expected from everyone in the hospital in its complexity, but patients need adequate anti-infective treatment, and therefore guidelines can help. It is very easy to have a guideline on the hospital website or something else, recommendation within the hospitals. And on antibiotic stewardship is also helpful, a very helpful element, because it educates and persuades prescribers to follow evidence-based prescribing to treat patients adequate. So we analyzed this again for the countries, and you see here a benchmark. You see here the results for antimicrobial guidelines in green for the different countries. The names are blended. These are the results for the European Union. And you see that we had some countries where guidelines are implemented, where they are present, they're on the left side. But you see also that there are some countries that are worse. They have not the guidelines in the hospitals, in all hospitals. The same applies for antibiotic stewardship. But the benchmark for these two elements is not the same ranking. You see here the lines. We have one top country, and this is not Germany, but the other ranking is very inconsistent, and you see some countries have antimicrobial guidelines, but they have no antibiotic stewardship. And this is only an example for the other parts of the survey, for the other questions like screening or the standard operating management. The problems are not similar in the countries. One country has the screening implemented and they have maybe guidelines, but they have no management protocol. And so you have a wide range of variation between the countries. So what is critical in the treatment of sepsis? Quality improvement programs are very important. 10 years ago, there was a hope in the guidelines. The committee hopes that over time, particularly through education programs and formal audits, feedback performance, this will improve the management and the outcome for patients with sepsis. And so we had enough studies within the last years about quality management. Here are some of the studies. We had meta-analysis, we had large studies, we had everything. So we need not more research on this topic. Other research topics are important, yes, but not for the screening or the simple management, the simple bundles. And here you can see the results for sepsis training and quality improvement programs in the European Union. Most of the hospital sizes have no sepsis training, no quality improvement, nothing like this in place, no audit, no feedback, nothing. And you can see here the room for improvement is larger than in the other results. Is 70% in the hospitals. And you can also see that we have, again, a large variation between the countries. Here's one country, there is training and quality improvement programs implemented. 2 to 3 countries are on a good way, but the other countries are very bad. So you can see here the rates below 30, below 20%. So there is no training, no education, nothing like that. So I will come to my end. I'd like to thank all the participants in this survey first, and also the steering committee, which organized and disseminated the survey. Our national coordinators were very important to achieve this high sample in this project. And I also want to thank the societies. You see here all the societies in Europe which endorsed this project, and this was very important for our success. So, yeah, my conclusion is we have a very large and well-distributed sample representing almost 25% of all beds in the European Union. But this sample could be a positive selection, yeah, because all the participants were interested in sepsis. They heard about the survey and the questions and said, yes, sepsis is important, I will take part, and I will share the structures of my hospitals. And I don't know how the results for the other 75% are. So these results can really be a positive selection. Essential recommended basic measures and structures are very often insufficient, and we see a lot of differences between the countries. So not the similar problems in Germany, like in Italy or France. And we can differentiate improvement approaches. They can be drawn up from for individual countries. And in the end, yeah, this is a little bit a recommendation. Audits could be an instrument to measure sepsis in reality, and and also to monitor the status of implementation. So thank you very much for your attention.
Thank you so much, Dr. Scheer. So I'm very sad that the United Kingdom was in pale blue on your slide, but hey. I find this really interesting, and I'd just like to reflect to those viewing and listening. This means that across Europe, 2 out of 3 of our hospitals, if one of your family arrives in those hospitals, the health professionals have had no recent training in sepsis or don't have a bundle of care or a pathway of care to direct their treatment, or both. This is awful for this very prevalent condition. I want to see whether you have any insight, Christian. We talk about antimicrobial resistance, and we know this is a big threat and a big problem. And your survey shows us that doctors are more keen to have the results quickly than to have precision, and I can understand that as an intensive care doctor. We need instant gratification. We want to know, what do I treat my patient with right now? I think we accept a lot of imperfection, a lot of bad systems in our laboratories, certainly within the UK. And if I may, I'll give one example, and then I'd like to see your reflection on it. Our guidelines committee, NICE in the UK, recommends that we give 2 antibiotics to everybody admitted with pneumonia, just in case they have Legionnaire's disease. So we admit 1 million people with pneumonia every year in England to hospital. We see 500 people with Legionnaire's disease. So the vast majority of these people need monotherapy, not dual therapy with antibiotics, but we give the second antibiotic just in case it's Legionella pneumonia. My laboratory batch the samples for Legionella to do on a Tuesday and a Friday, meaning that most of my patients receive 2 antibiotics for 3 or 4 days, and the vast majority don't need it. There are some issues with antimicrobial resistance that I think we could address very easily by improving the systems within our laboratories. Was there any insight from your survey, any comments that this was the case, or do you think the data or your personal experience support this?
Yeah, we have some more data about the laboratories and the opening hours. So we do not ask questions about the specific treatment, but a little bit more about the opening hours. And for Germany, for example, it's very interesting that we have laboratories which are not in the hospital, which are external. So the blood samples were transported to external laboratories, and so this was another aspect which causes delay, because the worst thing is if laboratories are external and they have limited opening hours, and the best case is if the laboratories are within the hospital and they have 24/7 service. So I think one very big topic for the future is that we have laboratories with 24/7 service, because sepsis is not only during the working hours,
of course.
It's also at the weekend, in the nighttime, and if you have myocardial infarction or stroke, then you are admitted to specialized units. They have 24/7 service. Why not for sepsis? Why are
totally agree.
all these laboratories closed? And I think this is very important for the future, that we have this structure within our hospitals.
Thank you so much, Christian. And I fully agree with you. We need 24/7 laboratory services. We're going to hear more about this in a moment from Gioia. But I think it's more than this. I think technology is accelerating, and point-of-care diagnostics and the technology behind them is accelerating at a rate faster than we can integrate them into clinical systems. And I think we have fantastic potential techniques for molecular identification of pathogens and resistance profiles, but we don't integrate them. They sit in these remote laboratories, and there's a huge time delay before we as prescribing clinicians get those results. We need to work much better at the integration of point-of-care diagnostics into clinical systems. So thank you so much. I'm just going to take one quick question. No, I'm not, because it's disappeared from my screen. So we're going to hear now, and we'll keep the theme going, from Gioia Babini, who's also joining us remotely. She is the Director of Medical Affairs for Becton Dickinson across Europe, the Middle East, and Africa. And thank you, Gioia, for sharing, I suppose, not only the diagnostics perspective, but also the industry perspective of this problem.
Yes, absolutely. Can you hear me well?
Yes.
Okay, thank you. Yes, and thank you very much for the opportunity. I've been listening carefully because this is a topic which is really close to my heart, and it goes hand in hand with the antimicrobial resistance one. And as you said, I've heard many different inputs, and I think we could talk forever here, but we only have a few minutes. And first thing is awareness. I would like to take that, a step back and say, listening to Linda, and it's really like that we need to act and do something and increase the level of awareness hospital-wide, because if you can improve diagnostic at the best you can, but then if the patient is not recognized at first, that needs specific attention, we're not going to get anywhere. So it's awareness, educational programs. At the emergency department, I was quite intrigued by the results. 80% of sepsis actually do present, at emergency department. And yes, in ICU, it's easier. And we saw that there was a much higher level of awareness, of screening, of, standard operating procedures and such. So one thing that it's close to me, and I heard this also from another sepsis patient survivor, it's just we need to think that behind every single sample there's a patient. So it's like, what is the value of that sample, that blood draw that we are doing, and not just specifically the blood culture, but really any blood draw that is done. That's key. The other point that you also raised is, the importance of speeding up the diagnostic. Absolutely, but there's also different ways of achieving that. You touch on the point of the logistics, and it's really like, you can speed up and have the fastest test on earth. But then if the results sit somewhere in the lab and is not communicated, it has no value. Equally, if something like as precious as a sample like blood culture can be, because helps identifying the pathogens, will give you the full susceptibility testing. If it sits for hours somewhere in a remote hospital, because it's a hub and spoke model that we're seeing more and more in Europe, or you don't have your own laboratory and you need to send it somewhere, and it takes 4-6 hours, a weekend waiting somewhere to be even introduced in a system, it doesn't work. So really this logistic part of the diagnostic, it's actually essential. So there's really so much that can be done, even by improving the way we work, which is why, very much appreciated the concept of, the learning, the having program in place that measures where are we, with this kind of procedure. How is diagnostic done? And there's small little things that, well, small, but anyhow, without even going to the super duper innovation in technology and spending a fortune and investing, because that also has an impact, right? But improving the way laboratories work. Is the blood taken in the correct way? Is it transported in the best possible way? Is it incubated in the best possible conditions? Is the information flow really working? Because, as I said, the test result sitting in the lab doesn't do any good if it's not reported immediately. So 24/7, absolutely, but there's also a number of, let's say, what we call a key performance indicator that could be monitored. If there is lack of awareness or where we are, where the practice is falling short of, if you're not aware of your mistakes, you can never fix them, right? And then, of course, it's the innovation piece. BD is committed to it, and we're working actively, and there's a number of other companies that are also investing in new technologies for, providing these rapid results, and obviously, everyone would wish to have the magic bullet that in less than an hour you would give the full answer and the full susceptibility profile. Can I use this antibiotic or not? But, I'm quite confident that we will get closer and closer. But as I said, we need to act on both ends, because innovation and automation, or, improving the lab piece without this holistic approach, this communication between where the patient is sitting and where the tests are taking place, I don't think we will see the same extent of results and impact. So, I really like this approach of being holistic, and it's really like, it's a little bit like this integrated diagnostic stewardship approach. You need to have the antimicrobial stewardship in place, not just a standard operating procedure which sits somewhere. Is it really lived? Are people aware of what it means? Is it known what is the level of resistance that is in the area? Because an empiric therapy is something that today we cannot avoid. But then are we conscious of where is the patient coming from? What was the exposure? What are the factors that are influencing, the conditions? What is the right empiric therapy? Is it really solid? And then, yes, do the best we can to provide results as fast as possible. Applying the best methods, or, using the best technology that is currently available to give that feedback back. And I would like to say one last thing. But then that feedback has to be used. So many times I've heard, and I'm not a physician, so please don't get any offense out of this, that you don't change a winning team. Okay, but I mean, if there are evidences that maybe the standard therapy is not the best one, can we de-escalate when it's possible? Can we escalate so often that dialogue is missing, and I think that even the antibiotics that still today work, yes, antimicrobial resistance is a huge problem, especially in some countries. I come from Italy, so you can imagine that for me, carbapenem resistance is all over the place, and it's very worrying for me. But I mean, if there is not that dialogue and really that, putting in place all the guidelines that, in many cases are available, I think then that we will minimize any possible impact, even at innovation level.
Thank you so much, Gioia. I'm going to sort of present you with a slight challenge, because you say you're not a clinician, but you're a scientist and you have a PhD in clinical microbiology, but you also sit in industry. I wonder whether industry and someone in your position becomes frustrated that we have a conflict almost between clinicians like me who want rapid results to give the right antibiotic to my dying patient at the right time, and then laboratory-based clinicians who want precision and have a risk-averse attitude and therefore don't communicate the results rapidly. And another example of the way in which our laboratories fail our patients is in many hospitals across Europe, blood cultures, if they're taken on a Friday evening, don't get loaded into the incubator until Monday morning.
Exactly.
And therefore, my patients are receiving a carbapenem or piperacillin azobactam for 3 extra days because the laboratory can't service the loading of those blood culture results. I know that frustrates you, but do we need to look at this dynamic of almost the conflict between me, who wants a rapid answer, and precision is maybe here, and a laboratory-based clinician for whom precision is here, and the urgency, because they're not in front of the patient, is down here?
Yeah, that's a difficult question. And I would say, yes, I think we need to talk, essentially. That one of the problems is that we need to put down this barrier, and if we look always for this 100% precision, we will never get there. So, and it's a matter of having a sort of an algorithm. I mean, we've been asking recently, would you like to have a magic tool that says if it is bacteria or viral infections, and then you decide? And some say yes, and some say, well, actually what I need, and it links a little bit to what you were just saying earlier, is something that tells me if my patient is going to deteriorate soon, and I really need to initiate the therapy right away, when I can still wait. So it's more like, something that would kind of provide you insight on on how the patient is going to react. Sepsis, it's an overwhelming reaction of the immune system, right? So the infection can be treated, maybe we can wait. So I don't want to confuse scenarios even more, but I think where I've seen things working, or anyhow like improvements, is where there is really this dialogue, between the treating physician and the laboratory. There's compromises that we have to make, because the magic bullet doesn't exist. And, we don't have this perfect algorithm to triage patients and to say, this is the patient that really needs the most urgent care, and then I cannot afford to wait for anything. So of course I will give all the antibiotics I can. But in other cases, maybe you could. And is it related to the immune system? Is it related to your profile? Is it related to the infection? The truth is that it's such a complex scenario that if we keep working in silos, and this is my patient and I treat it with the antibiotics I have. That's a sample taken, some time, transported. It's not my problem. I don't need to transport the sample. It gets to the lab at some point, and the lab works up when I'm open. When I have time, it's sitting somewhere.
Of course.
There is not really that feeling of, and that's why I say, and I feel it, like there is a patient behind every sample. If
Absolutely.
That is not considered, and we lose, and I understand it's a way of also sometimes protecting ourselves, but we need to think that there's a life behind that, and then really work, not in silos, but in a holistic approach, in a coalition mode.
Thank you. So
that's what I try, at least also from my end.
What I take from this, it's breaking down silos, it's collaboration, it's accepting that the tests are not yet perfect, but empowering clinicians to make the right decision in partnership with their infection specialists. And thank you, Dr. Babini. And speaking of infection specialists, we should move on in the interest of time with respect to the next speaker, who is a professor of infectious diseases, working out of Stockholm in Sweden. And Professor Strålin is going to tell us about the improvement work that's going on in Sweden. I would just reinforce, and I'll take one question before Professor Strålin comes in, but I would just reinforce, this is one example of good practice. There is good practice going on in many countries in Europe and throughout the world. Please, the one question. And if we could keep it moderately brief,
Thanks.
please.
Yeah, very quick, Magda Rosenmüller. I was very surprised that you did not, exactly for this accuracy versus quick decision, you did not mention, and Gioia did not mention the rapid testing, like COVID testing, where I can actually at least AMR resistance, I can get a better idea of how I can move on quick. And you didn't mention that at all, so I'm a bit surprised about that. I would love to know why you didn't mention that. Thanks.
Time is the simple answer, but this is about the integration. It's an ecosystem of devices. So we have lateral flow tests. They're not perfect, but in the context of clinical assessment of our patient, they can empower us to make the right decision. And I think it is important, but it's about breaking down silos, it's about empowerment, and it's about accepting imperfect precision with these tests and trusting health professionals to make the right choice. I totally agree. I describe this as an integrated ecosystem of devices, and that's exactly what we need throughout healthcare systems. So please, Professor Strålin.
Thank you very much. Do you hear me?
Yes.
And you see this slide?
Not yet, yes.
Do you see it now?
Yes.
Yeah, okay. Yeah, so I'll tell you a little bit about the Swedish sepsis healthcare process. So it was in 2019 that the Swedish government allocated 90 million euros for standardized national healthcare processes. And sepsis was selected as one of 10 initial diagnoses for that project. So we were very happy about that. And I was the chairman of this working group that has worked with the national healthcare process. And as you see in the middle, we were 19 experts, physicians and nurses from different clinical competences, and also a patient that worked with this healthcare process. And it was approved by the Swedish healthcare directors in May last year, and is currently being implemented throughout Sweden. And we have focused on 3 different interventions in our healthcare process. The first one is to implement sepsis alerts in all emergency departments in Sweden. As we heard before, there were about half of the emergency departments that had sepsis alerts. And the second intervention is to improve the appropriate sepsis coding after discharge or death, so we can have a better picture of the burden of sepsis within our healthcare system. And partly we do that by an automatic sepsis SOFA score calculator within the electronic record system. And the third intervention is a clinical follow-up in a structured way after discharge, because that's completely lacking in Sweden. And to the right then, a very important part of our healthcare process is to do surveillance of the population, to have an electronic process monitoring. So we're currently building up an automatic surveillance system of the sepsis population that comes to the emergency departments, and also about the sepsis alert population. And we have identified 12 different quality indicators, survival and hospital-free days up to 90 days, and also a number of process indicators such as time to lactate, time to blood culture, time to antibiotics, and also if an intense infectious disease specialist is involved within the first hours in order to enable appropriate antibiotic therapy. And finally, I just want to mention that we've done also a health economic analysis. We found out that the sepsis alert will require a little bit more staffing, but as we we'll do things more appropriately in the beginning, we'll most likely have shorter hospital stay, and therefore it will be cost saving. And the clinical follow-up will require new nurse time and new doctor's time, but we found out that most likely it will reduce the readmission frequency. So this health economic analysis was important when we convinced our directors that this is very important, also from a cost perspective. Thank you.
Thank you so much, Professor Strålin, and thank you for keeping it brief as well. I mean, I'm really interested in this health economic analysis, and we will open up questions briefly to, I don't know whether you've seen the data from the Canadian Sepsis Network that shows that for every Canadian dollar invested in improving sepsis outcomes, there's a return on investment of 112 Canadian dollars. So I think if we can demonstrate this in Europe and demonstrate to our policymakers that we can't afford not to prioritize sepsis, as Sweden is doing, we will achieve huge improvements. Have you reflected and seen that data?
No, actually, I have not seen that data, actually. But we have done in Skåne, Malmö, Marie Rosenqvist has done a part of a healthcare economic analysis that has been published. So we have some Swedish data as well, but I will be happy to look at the Canadian results as well.
Perfect, and we very much look forward to hearing more output from Sweden and you know, really leading the way with this government-level investment. I think many governments have issued action plans but just instructed their healthcare system to improve things. Your government has put their money where their mouth is, to use an English expression, and really helped you to drive this process. So, fantastic example. Thank you so much. Any questions for Professor Strålin before we move on? So there's nothing appearing on my system. There's a question that I'll address as we sum up. Thank you once again, Professor Strålin. So our last speaker, we are very lucky to have. Janet Diaz is a pulmonologist and critical care specialist, but she's been quite busy over the last couple of years because she leads the team within the World Health Organization dealing with emergency response to emerging infectious diseases. So we're very lucky to have Janet. And really, your remit, Janet, is we know that we presented a resolution to the World Health Assembly in 2017. We know that it was adopted as a WHO resolution. We've been distracted over the last couple of years, but what are we now going to do within the WHO to ensure that we can connect these dots, that we can bring this together? Please, Janet.
Thanks so much, and it's a privilege to be here, and good morning, colleagues. So I was asked to see how we can connect the dots, how WHO can support these efforts, and I think from the previous speakers, it's quite clear how kind of a complex and interrelated piece of programmatic work this is that entails, even within the WHO, multiple different programs, departments, and I think what we have to consider at the highest level is kind of a very coordinated but comprehensive approach of sepsis care and clinical care. And I was asked to kind of take the patient-centered focus to this, and I do think it is important to do the patient-centered approach and think about it in a patient-centered sepsis care pathway. And if we start to look at that from beginning to end, you know, to full health, hopefully to recovery, then maybe we can start to put all the elements that have been actually discussed today already. And I'm just going to highlight a few. Even before we start, we have to focus on prevention. Prevention of sepsis is key, and we cannot forget that. So prevention, we bucket into two big lumps. One would be vaccination. So making sure vaccine preventable diseases, both for disease or vaccines that prevent severe disease, as we have with COVID, and prevent death, that the right groups are getting vaccinated at the right time with the right vaccine at the right protocol. So I think that's an important aspect, and that has to be done at the primary care level, you know, integrated into primary health care, pediatric care, potentially clinics where non-communicable patients who have non-communicable diseases, chronic diseases are being cared for. So really all the opportunities within the healthcare system for prevention need to be highlighted there as a prevention for sepsis, severe death. The second part of prevention, we kind of put in the lump of infection prevention and control. Again, that has to be done both in the community and in all health parts of the health system. Again, focusing on primary care, pre-hospital care, and then, you know, within the hospital, which has been the bulk of the discussion today, including wards as well as intensive care. So infection prevention and control programs at the facility level, at the subnational level, and at the national level to ensure prevention in that manner. The second major intervention is early recognition. And that has also been mentioned. And I would say here, it's a little bit more, there's more that we need to develop and disseminate and study, I think, right, in this topic. Early recognition, you know, we can see in patients present in two pathways. One is they're undifferentiated, undiagnosed. They don't come saying, I have COVID. They come saying, maybe I have a cough and shortness of breath and a fever. So we need to understand those kind of syndromes that are concerning for sepsis. And we need to learn more about that because that may be different in different parts of the world. You're getting the European experience here. You know, I work in Geneva, so I do kind of support all the regions of the world, different pathogens. Some are endemic, some are emerging. So what are the undifferentiated syndromes that we need to keep an eye out that with the train frontline providers and recognizing? And then we have people who actually do know they have COVID, right? They got their own test at home and they come in with this, and we need to make sure we understand how to risk stratify those patients about signs of severity, about signs of sepsis, so that they get the right treatment at the right time. So that's the clinical side. Then it's the diagnostic side. And as the colleagues have already described, diagnostics is key. You know, access, so it's access to diagnostics, and it's the right diagnostic. It's, again, based on the local epidemiology, what is circulating, what do you see? It's viral diagnostics, it's parasite diagnostics, you know, in certain parts of the world, access. It is bacterial diagnostics and rapid turnaround time. And that's key, right? Because it's not just that we talk a lot about point of care testing, which I do think has, you know, been a revolution in trying to get getting results back to practicing clinicians so they can use those results. But like as the colleagues spoke previously, right, that even if you put these systems in place, that the communication and the interpretation of this test result to the provider and how they use that to change, potentially, you know, fix their antimicrobial rate. So it's not just the test itself, it's actually the actions taken after the test. So there's that process that needs to be into place, but the early recognition requires both the syndromic clinical side and what we would like at WHO is access to right diagnostics. And COVID was a good example, I think, of that. And not all the diseases have that available, right? So some are lacking and some were, you know, highly advanced in that. Or developed in that. So that's innovation in diagnostics, which I think is important. Those are disease-specific, and I just mentioned disease-specific diagnosis, which will help us with antimicrobial therapy. But then also diagnosis of, and you know, when we talk about sepsis, acute organ function, how are we evaluating organ function, right? How are we evaluating with, you know, potentially point-of-care arterial blood gas machines or other point-of-care testing? And this may not be a big issue in many European countries, perhaps, where there is, you know, more diagnostics perhaps potentially available for supportive care interventions, but it is a big issue in certain lower income or resource-limited settings where access even to a creatinine, a hemoglobin is a challenge, and we do need those in order to give the best supportive care interventions. So I think, again, the access to the testing in the right settings, again, it can't all be in the hospital, it can't all be centralized depending on the disease. Some has to be in primary care, some has to be in the pre-hospital setting, and some in the hospital setting, and that takes planning. Moving on to the next two aspects, treatments. And so we discussed treatments. So again, early disease-specific treatments are key. Right, we can see that from depending on the different pathogens, that treating the pathogen, if there's an antiviral or an antibiotic, or, you know, if that anti-pathogen exists, then, you know, giving it early, giving it to the right patient, we do hope saves lives. And we've seen that a little bit, you know, we've seen that with COVID for the early use of antivirals, but at some point, potentially, that's not enough. So getting the right drug, again, that's access to the right therapeutic, understanding, you know, with good efficacy and safety data, what is the right treatment options depending on the pathogen that you have diagnosed the patient with, and trying to get that onboarded. So I think that's an important aspect. But I also wanted to highlight access to what we learned from COVID, again, trying to take lessons learned from other serious diseases that have caused significant burden of death through sepsis, is the use of immunomodulator therapy, right? This is something that we have discussed with sepsis for a long time. And good studies done during the COVID pandemic have shown some, use cases, improved mortality in patients who have severe critical disease that were treated with corticosteroids, something that also we've been studying for a long time. So again, maybe this is not for all pathogens, but it does imply that, potentially be a right role of immunomodulation and certain elements of sepsis, depending on the pathogen, still a continued area of research and possible clinical effectiveness pathways based on research. I want to also remember that treatment, like someone also said, no magic bullet. A treatment, an antiviral on its own, an immunomodulator on its own, they don't save lives. It's actually in combination with good supportive care. So here I would, emphasize the good basics of, good supportive care, oxygen therapy, advanced respiratory support devices depending on what is needed, fluid therapy, the right approach to fluids depending on whether or not you have Ebola virus disease, COVID, or intra-abdominal infection. Again, nice appropriate use of fluid resuscitation in patients with sepsis. And then finally, the last thing that I will end with a short time frame, is post-acute care. And we've already discussed this too, the recovery period, the survivorship. Again, COVID has made us learn big lessons from that and has our experience in critical care over the 2 decades. So one is like disease-specific, potentially disease-specific, pathogen-specific prolonged effects as we're seeing with long COVID or post-COVID-19 condition or post-viral syndrome. The other is actually more syndromic, such as the post-intensive care syndrome that we see with critically ill patients that have had sepsis, regardless of the pathogen. So we just need to be alert that there's this group of people who get infected, who develop sepsis and recover, and then have prolonged symptoms, prolonged limitations. And I think the common theme there is that the health system does need to address multidisciplinary rehab, as already mentioned, really important, including other specialists as needed, primary care, social work, mental health, psychosocial support, et cetera. So if we look at this paradigm, I think within WHO, there are many different areas to make interventions, but we have to build the story and then put the puzzle together. Not every part is important, and every part depends on each other. But if we can do this, with shared responsibility in a coordinated fashion, make sure that the financing is in place in the health system to do this, because this does require health financing, but we do hope that the cost effectiveness of these, comprehensive programmatic approach to sepsis will reduce lives and improve care and make people continue to have happy and productive lives. So thank you for that opportunity.
Thank you so much, Janet. And I'm going to paraphrase you really as I sum up, but I would also put to you that we can't achieve this, and I think it's got to be said, without proper partnership across the private sector, the public, non-government organizations, and state actors and governments. This has to be a collaborative transformation. But thank you for the WHO's initiative. Idelette, we have 1 minute. Please, would you?
It's working? Yeah.
Yeah.
Yeah, and collaboration with the patients.
Yes,
because
absolutely.
I'd like to visualize, I felt myself like in a life-saving boat on a large ocean. I was grateful for the life-saving boat, but I had no paddles, Yeah. We should give those patients paddles and work together. The Global Sepsis Alliance took the lead in combining the attention for COVID and sepsis. That's really good, because we need to exchange more knowledge. There's so much knowledge about the sequelae of sepsis and the mechanisms that are driving them, about the mitochondria and the impact on the brain. We should exchange more and take it seriously. And I would like to call for a sepsis expertise center where general practitioners and all kinds of doctors can get their information from about the sepsis aftermath, so they can support their patients in a better way. Because when you go to your general practitioner and you talk about the brain fog and I can't do multitasking anymore, you're often not being taken seriously.
Thanks so much, Idelette. And I totally agree, but we do have to close the session, and I'd like to thank our panelists. I'm sorry that we haven't had as much time as we would like for dialogue. I think we've done it as we've gone along. I'd like to thank BD and the European Sepsis Alliance for bringing this meeting together and for the audience participation. We have learned about an incredibly prevalent problem that claims more lives internationally than cancer. A problem which is underfunded, a problem which transcends all aspects of our healthcare systems and our broader society, and that is intrinsically interlinked with antimicrobial resistance as the final common pathway to death from most infectious diseases worldwide. We've learned about the importance of public awareness, health professional education, pathways and bundles and training for health professionals to enable them to do the right thing, better diagnostics and better integration of diagnostics, including rapid diagnostics, and the importance of end-to-end care, from infection prevention right through to rehabilitation for people affected. We can't afford not to do this. Idelette has shared her story. But remember, around the world every year, there are 38 million people like you who survive this condition and are left broken and struggling to recover. So thank you so much for your attention. Thank you for listening to this session, and we shall bring it to a close.